Get start, we're going to move on to the next sessions. Um, Before that, I would like to remind you that you have evaluation form in your bag. Please send those evaluation form to the people, to our staff, to get the feedback from you. And this session is interactive session. We're gonna have questions for the audience and for the expert, and we can get the vote from e-voting system. I think you're already familiar with this system already because it has been used for 2 days, and you have the paper, the page in your bag. And today for this session, you use QR code to scan. QR code reader to scan the QR code at the top right of the pages. It's my pleasure to introduce our expert in the panel that we're gonna discuss about how to give antiretroviral therapy in real life practice. The first expert is Dr. David Cooper from Australia. He is director of Kirby Institute of Infection and Immunity from University of New South Wales. And the second expert is Professor Juergen Rockstroh. He's head of HIV Outpatient Clinic, University of Bonn, Germany. And the last one, we have Dr. Juergen Rockstroh. She's from Chonburi. Very sorry that we don't have Peter Reiss for this session. When we talk about giving antiretroviral therapy to HIV-infected patients, we're going to start it with when to start. But I think that today we agree that we have solid data when to start already, because there are so many clinical trials that has been shown benefit of giving ART to HIV-infected patients at any level of CD4 count. This is the example of the clinical trial that's shown a benefit of giving ART in patients with higher CD4 count. Giving ART can prevent the occurrence of tuberculosis, lymphoma, Kaposi sarcoma, even in those with high CD4 count. Not only reduce risk of serious AIDS-related events, giving ART also reduce rate of serious non-AIDS events too. This is another study from African countries. They show similar findings. Giving ART can protect them from adverse events along with giving an prophylactic therapy. This is the objective of the presentation. After presentation, the audience could be able to choose the first line for treatment-naive patients in various settings. And the audience can then describe the impact of giving ART in pregnant women to reduce risk of HIV transmission from mother to child, and what is the best option for HIV pregnant women. And the audience can also discuss the data supporting switching strategy in patients with virologic suppressions. And lastly, the audience can manage patients with second and third line ART failure. I will begin with the cases, and I will get the answer from the audience, and then gonna ask the thought from the expert. Begin with case number 1. The case number 1 is young MSM HIV-infected patients. He present to the clinic with a recent diagnosis of HIV infections. He had history of gonococcal urethritis 1 year ago, and he admit that he had multiple anonymous sexual partner, and he also used he is active drugs user. He used heroin, and at the baseline lab, his CD4 count is of 892 cells per cubic millimeter square. His HIV viral load is 90-100 copies per ml. His VDL is negative. His hepatitis serology, including A, B, C, are negative. We also sent HIV genotype, and it came back, turned to be Y type. I would like to ask your opinion on the ART regimen. Which ART regimen would you suggest in these patients? A, TAF, FTC efavirenz. B, TAF, FTC rilpivirine. C, abacavir, 3cc dolutegravir. D, TAF, FTC plus boosted elvitegravir. Or E, TAF, FTC boosted darunavir. Please vote. Okay, I think most of us think about TAF, FTC efavirenz, and followed by abacavir 3TC dolutegravir if HLA-B star 5701 is negative. And small number of us choose TAF, FTC boosted darunavir. I think there's no one right answer because I think I want to see this. I want to see the contribution from the audience and from the expert. How would you choose the first line regimen in this patient? I will begin with Professor David. What is your thought?
So I think you can see the spread. I guess most people are comfortable with the standard guideline in low and middle income countries, which is efavirenz. I think in first world countries, I think we're moving towards integrase inhibitors first line. And whatever we choose, I think in initiating antiretroviral therapy with a wild type HIV, the fixed dose combinations are very useful. I'm not sure yet about the widespread availability of TAF, at least in low and middle income countries. I guess it will come, but certainly it would be now preferred over tenofovir. I also think that option E, which is first-line protease inhibitors, is really very much going out of favour for first-line. And I think rilpivirine in a person like this with almost 5 logs of 96,000, which is pretty close to 100,000 viral load, I'd be very nervous about using rilpivirine. So that they're all good choices, but the guidelines in this part of the world would favour efavirenz. I think in rich countries we're moving towards integrase inhibitors, and I think that will progressively happen elsewhere globally.
And Professor Juergen, what is your idea?
Well, obviously I would always agree with David, so difficult to say something against that. I think the first thing to say is, though, that obviously the great thing is that we have choices. And if we have choices, I think we have to tailor that down to the characteristics of the patient. And the patient has a history of ongoing heroin use. So you would at least speculate whether there might be an adherence issue. So I think taking into account a regimen which has a high genetic barrier would be something in my clinical practice which I would favor over regimens which are more fragile. So for me, rilpivirine, which has to come with a meal in someone with IV drug use, I find a little difficult and challenging. David mentioned the sort of threshold of 100,000 for rilpivirine use when you're naive, so that's another aspect. So that wouldn't be among my favorite choices. So I would probably go rather for the dolutegravir regimen or the boosted darunavir because of the high genetic barrier and ongoing IV drug use.
And อาจารย์จุริรัตน์
Thank you, Dr. Opass. Please go back to the history. Just to clarify that the session is the real life. My real life is I'm from the public hospital in the east part of Thailand and have to treat the patient according to national NAT program, which is available only the very limited of choice. So we have to my real life. Okay, just to discuss that this is a very challenging case because he's very young man. When you got the case of the MSM and had the gonococcal disease, automatically you have to check VDL. I'm a bit disappointed that this case VDL is negative. That means that he may be careful in terms of the safe sex or something like that. Or maybe I may recheck the VDL first. Okay, the second point is IVDU. Is maybe now today, this is the old case or the current case?
This is new case.
Old current case?
Yes.
Usually the fashion nowadays, the teenager did not use the IVDU. Usually they use the methamphetamine or ice better. Yeah, so maybe it's a little bit unexpected. Okay, anyhow, if you have the case of the IVDU, you expect that the HCV antibody should be positive. But in this case, again, it's negative. You mean the hepatitis serology is
Yes.
B and C?
I check all A, B, C.
Yeah, so it's a bit negative. Okay, we already have the CD4 is very high. But if this case CD4 is lesser than 100, remember that the HCV antibody may be negative because it may be false negative. Okay, anyhow, to the choice. If I have to treat the patient in Thailand, we start with the NNRTI because of the cheapest. And maybe it's, nowadays we have the fixed dose combination single pill. For me, the choice A, not A, we did not have the TAF at all. We have the TDF, FTC, and F-valent. So if I have to choose between NNRTI, PI, and integrase is a dream nowadays in Thailand. PI, if you have to choose between the PI and the NNRTI, what different? The difference is the adherence. For the NNRTI, if you have the single pill regimen, maybe it's better for them. But if you use a NNRTI, you have to think that will you give him the methadone maintenance therapy or not in this case? Another point in the real life. If you offer him the MMT, methadone maintenance therapy, remember that there is an interaction between the NNRTI and the methadone. The level of methadone will reduce. And we have the experience that some of the patients experience the withdrawal methadone therapy. So in this case, my choice, okay, I have only one, A or B, but maybe start with A because Leuprolin just available in the NAP program this year. And I will discuss with him about the MMT.
Yeah, well, actually, in Thailand, we don't have TAF available right now. We're going to have TAF in next few years. And dolutegravir will be here, will be available, I think in May. So we try to prepare you for this kind of drugs. However, we have this. We don't have TAF now, but we have TDF, and the choice may be ALB for Ajahn Jurirat, right? When we look at the guideline, this is a comparison of Western guidelines. I look at the guidelines from the US, the HSS and IS guideline, and I took one from European guideline and to compare with the WHO guideline on your right, on your far right. We could see that the integrase inhibitor is becoming popular, and it has been used and recommended in many guidelines, especially from Western world. And all of them is now in the preferred regimen, including dolutegravir, elritercept boosted with cobicistat or raltegravir. All of these three are in the recommended regimen for HIV treatment-naive patients. For PI, only one PI survived in the guideline, boosted darunavir, because I think because the safety and tolerability that the boosted darunavir has higher than its counterparts. So darunavir is recommended in the HS guideline and EASC guidelines in combination with 2-NRTI. For NNRTI, rilpivirine is in the list of preferred regimen in European guideline, but before use rilpivirine, you need to check baseline HIV RNA. It should be less than 100 copies per ml, because if the patient has higher baseline virus greater than 100,000 copies, the patient might have suboptimal response from this regimen. When we look at the WHO guideline, efavirenz-based regimen is the preferred regimen. And look at this. In the WHO guideline, it's also recommend reduce to 400 milligrams of efavirenz in the alternative regimen, as David mentioned this morning about ENCORE study that support that efavirenz 400 milligram per day can be used if the patient has a problem with 600 milligram per day of efavirenz. And in the WHO guideline, dolutegravir is in alternative regimen. Although the WHO recommend use of 400 milligram of efavirenz in treatment-naive patients, you need to be very cautious when use this. It should not be used in patients who receive rifampicin because drug interaction, and it is not recommended in pregnant women. We're gonna have all of this soon, dolutegravir, elritercept, and raltegravir, but we have limited experience because we don't have dolutegravir now in Thailand. We have elritercept boosted with cobicistat, and we have raltegravir. So I would like to ask the expert opinion. What is your preferred choice of integrase inhibitor? I'm gonna start with Juergen first. So.
Yeah, sure. So I think, again, it depends really which patient you're looking at. I think the advantage of dolutegravir in the available integrase inhibitors is the high genetic barrier. So basically in all the first-line trials there's been no description of resistance, and so obviously, particularly if you have a patient like the one you described where you don't know how adherent he's going to be, there is IV drug use in the history, all that suggests that there may be an adherence challenge, and that's why I think taking or selecting a regimen with a high genetic barrier sort of has that advantage. Whereas boosted abacavir, which comes with the obvious advantage of having a fixed dose combination, including TAF, or if you have the other formulation with TDF, which may be interesting for that patient because his HBV serology is negative. You also have a protective effect against hepatitis B infection, and someone who has multiple sex partners, MSM, continues to have a risk before vaccination kicks in. So abacavir may not be the ideal choice, and you obviously then have everything in one tablet. But the patients who fail in the boosted abacavir do fail with two-class resistance. So I think the genetic barrier is not very high. If there's an adherence challenge, that would not be my preferred regimen for that very reason. Raltegravir, I think, is from a tolerability side probably the regimen with the best adverse event profile. So it really sticks out as a drug which is used in patients where you think you're going to experience a lot of side effects, particularly in patients with complex regimens, patients who have malignancies or are going to undergo chemotherapy, really becomes a preferred choice. But the twice daily administration in a very young patient of 21 who seems to be a party boy, I think it's just not going to help because you're overestimating what a person can deliver who's never been on a therapy, and with 21 to start a lifelong medication is a real challenge. And that's why I think a BID regimen per se would not be an initial choice for that reason. I mean, obviously there is a new formulation underway, and I'm sure that by the end of the year we're going to see a different formulation, and then that may change things.
And what about you, David Cooper?
Yeah, look, I don't really have much to add to what Juergen said. I really don't find much of a difference between any of those three integrase inhibitors. I think we tend to perhaps overemphasize the fine differences, the minor differences between them. And it may be that this guy would do just as well on a dolutegravir regimen versus a raltegravir or an alvitegravir regimen, notwithstanding the nuances that Juergen said.
I do not have the experience about the integrase, but if he is my patient and if he is affordable, if we have a choices, I still not give him the integrase as a first line because I'm afraid of the adherence. I will test him the adherence. It's just only simple NNRTI based, and if he can pass and he show that the adherence is okay, and maybe. Yeah, and the second point is I have mentioned that IVDU is now not the fashion addict in the teenager. Usually it's ecstasy or methamphetamine. So if you have to prescribe the antiretrovirus, remind that the ritonavir have the drug interaction in terms of the metabolism with the ecstasy. So if you have to use a PI base, be careful.
Yeah, for raltegravir now, it's recommended to have BID dosing, but we're gonna see data of OD once daily raltegravir soon, but we have to wait this data until it's become available.
I have to preserve because I'm avoid of the failure, and we will have no choice for the rescuing him.
So I'd like to tell you a little bit about TAF. TAF is new drugs that this is a product of tenofovir. TAF is converted to tenofovir in the body and have greater penetration of tenofovir into the target cells and leave small number of tenofovir in the system for systemic exposure. This is the reason why TAF has lower side effect, for example, lower bone toxicity and lower renal toxicity. In many trials, has demonstrated switching from TDF to TAF associated with improvement of renal marker, including higher eGFR or less proteinuria. That's the marker of proximal tubular injury, and switching from TDF to TAF also associated with improvement of bone mineral density. So this is a safety profile of TAF over TDF. So TAF may be one of the choice that if the patient have bone problem or kidney problem, we can start with TAF or switch from the other regimen to TAF. However, we need to know a little bit about drug interaction. Although TAF is good for bone and for renal, but the problem of TAF is in place where tuberculosis is prevalent. You need to know that TAF has major interaction with rifampicin. For example, rifabutin, rifampicin. These drugs have major interaction with TAF. It reduces the level of TAF significantly, and giving TAF with this agent must be avoided. So this is limitation in our setting because we have tuberculosis patients that we need to be aware. For the backbone, we have plenty. We have choice for the backbone to NRTI, and most of the guidelines recommend abacavir plus TTC, TDF plus FTC, or TAF plus FTC. How would you choose your backbone in your practice? I will begin with David.
I think in my practice in a high-income country, I think that FTC TAF is a very good choice. We also use abacavir 3TC, particularly because we can easily do 5701 testing. I think the data about TAF with bone and renal is very, very good, very strong data, and I think we do need globally to change from tenofovir to TAF for several reasons. I think the safety and the toxicity, and also it's 25 milligrams instead of 300 milligrams, so that's a significant price differential to enable us to treat more people. One of the things that has sort of surprised me is the rate of renal events in people in tenofovir on low and middle income countries, and when you start to have so many people, renal monitoring becomes overwhelming. So I think TAF will be a good option in low and middle income countries. So therefore it becomes very urgent to know if that interaction between rifampicin and TAF is important enough to push the dose of tenofovir down to below the threshold for efficacy. So on the one hand, I think it'd be a great move for cost and for toxicity, but we absolutely need the data on tuberculosis as soon as possible.
What about you, Juergen?
Yeah, so I would say that in Germany there's a much higher use of FTC TAF or FTC TDF than there is for abacavir and 3TC. And the reason is obvious. First of all, there's only one single tablet regimen which contains abacavir, so that sort of is a limitation in itself. And then I think for a lot of people in a country where half of the patients are now 50 years and older, the cardiovascular risk just plays an important role, and you may believe this story or not, but I would say that in the setting of having choices, why would you use abacavir in someone who has a high cardiovascular risk profile? Half of the patients are still smoking, so being predominantly a country where HIV patients are male, smoking, above 50, you already have quite a number of risk factors, and for that reason, abacavir is just not a very attractive choice, although HLA-B5701 testing is regularly implemented, but the lack of availability, obviously, with other combinations in a single tablet regimen, plus the cardiovascular risk, I think, refrains from a more dominant role of abacavir in this context. Obviously, the way forward is that people are now looking at dolutegravir plus 3TC, and that may actually be a replacement of the abacavir 3TC dolutegravir altogether when more data comes available. I think the discussion around TAF and TDF in Europe is a little bit different. Not every country has bought into the advantages, and I think that has a lot to do with pricing issues as well, but I think it's all about that if you look at asymptomatic young men, there is not that much difference in renal markers and bone mineral density. However, again, if you are looking at the above 50, it really plays out, and particularly if you are in regimens where you have TDF combined with a boosted PI and you have an increase in your tenofovir exposure, that's where you really increasingly in all cohorts see quite considerable safety issues around renal toxicity. And I think if you are seeing a large cohort of patients which are aging, like my own cohort, this has become the most prominent toxicity finding. And so I think TAF in a setting like the German one where the price is exactly the same, then you sort of see no reason to continue using TDF and switch everyone to TAF for that very reason. And I would agree that with regard to renal and bone at least in an aging patient population, that is the best choice we have right now.
Any input from you, Ajahn Thurirat?
Yes. Abacavir just available in NAT program in Thailand in June last year. And it is not recommended to be as a first line drug recommend. But it maybe have indication if you confront with the case of the compromised renal function. Maybe I avoid to use the TDF. And I also have the case that consulted to me that they start the TDF-based regimen in the elderly patient without cautious about the clinical lens. So the abacavir at that point maybe have an alternative to the TDF. And another chance is in the patient which have the hepatitis C and compromised renal function. This one is maybe prone to have the proximal tubule damage from tenofovir. So if you have to start the tenofovir base in the elderly patient, in the hepatitis C patient, in the compromised renal function, be careful. And maybe at that point, abacavir may be an alternative.
Yeah.
Thank you. So, in practice, we have many choices for choosing the first line regimen for our patient, but it should be individualized. It depends on many factors. It depends on the patient wants daily regimen or the patient wants single tablet regimen, the financial support and comorbidities. This slide summarize the setting and the choice of ART in different settings. For example, in hepatitis B co-infection, you should provide TDF plus FTC or TAF plus FTC as a backbone. And in TB co-infection, please do not use TAF. And efavirenz at 400 milligrams is not recommended. And we should avoid PI-based regimen or elvitikavir cobicistat in this case with who receive rifampicin. In patients with chronic kidney disease, we should avoid TAF, and we prefer to use abacavir we should avoid TDF and use abacavir or TAF more. And in cardiovascular disease, should avoid TAF, should avoid abacavir and boosted lopinavir.
Can I add one thing to that slide?
Oh, sure.
So for the hepatitis B, I just want to say that, because in clinical practice, what you often see are patients who have chronic hepatitis B are on a TDF-containing regimen, and then they develop renal issues, and the GFR goes down, and then you wonder what can you do to maintain HBV suppression. So I think it's one of the real clinical complications you see. And the problem is if that patient in the past has been exposed to AZD3TC and had HBV and has HBV resistance against 3TC, and you then switch the patient to entecavir, as you say up there, then that patient will not respond. All those patients relapse. There's quite a number of case series showing that entecavir in patients who have 3TC-related HBV resistance is not strong enough, even in the higher dosage, to suppress patients adequately. And so in clinical practice, what we've done at least is mostly that you then really have to watch your GFR, because if the GFR goes below 50, you can stagger your TDF and you give a tablet every second day. Or actually that is where TAF may actually be really a great addition to the armamentarium. And it's also, at least in France, has been the only expanded access indication has been chronic hepatitis B with renal issues to use TAF in that patient, because that will remain suppression. So you have to be careful. Just remember that entecavir is not necessarily a solution if you have 3TC resistance.
Okay, thank you. Very good point. We will move on to the second case. The second case is a 28 years old woman. She presents to antenatal care clinic at 12 weeks of pregnancy. This is her second baby. Her first baby was delivered 2 years ago, and that time HIV test was negative, but turned to be positive at this antenatal care visit. Her current CD4 is 545, and her viral load is 39. 1,000 copies per ml, and her hepatitis B and C serology are negative. Her VDL is non-reactive. So what is your ART regimen for these patients? A. TDF FTC efavirenz. B. Abacavir 3TC dolutegravir if HLA-B star 5701 is negative. Or C. TDF FTC boosted abacavir. D. TDF FTC boosted PI. Or E. You have the other choice. Please vote. Okay, good to see this. Most of us choose A, few choose number 4. Wow. Okay, you have your own choice. Wow. Sorry, four people have their own choice. I don't know what. Okay. What is your thought, Ajahn Juliat?
Okay, again, back to the history. The first point is that last 2 years she is negative, but later on she is positive. So my first question is she changed the partner? Number one. Okay, that is just only the reflect. Okay, and okay, go to the result. The result. Can you show the result? No. Okay, there is a 4 person choose the choice E. Maybe I also one of the 4. But the choice A is the point is that how confident that we will use the efavirenz in the first trimester. This is remind me to the year 2005 when the drug company launched the Dear Doctor letter that the efavirenz has a side effect of neurotil defect. It took more than 7 years until 2012 that the French group report in the CROI that they have the confidence for using efavirenz in the first trimester, and followed by the WHO guideline in 2013 and then 14 by the DH guideline the last. If we choose the first choice, efavirenz, only one point that at the 3rd trimester, whether the level of efavirenz is high enough. We have already conducted this study with him to show that in the 3rd trimester, the level of efavirenz in Thai pregnant is high enough to use, so we did not increase the dose. For the choice C, maybe in regarding to the Thai guideline, lopinavir still be the drug of choice for the pregnant because of the confidence of the potency. What we have to be careful is only the side effect, the tolerability of the lopinavir base and the level at the 3rd trimester. But we again have proved that it's enough. We did not need to increase the dose in the 3rd trimester. For the B, C, D, I have to leave for my panel.
What about you, David? What is your choice for these patients?
Me?
Yes.
Okay. I thought you were, yeah. Okay, so the first thing is that WHO went to an enormous amount of trouble when they recommended one regimen for all, tenofovir, 3TC, FTC, efavirenz, to put out a very strong analysis of the fact that the association of efavirenz with birth defects was not, was not a very clear association, and it probably was not, was not sufficient enough to actually worry about it in the long term. And and WHO debated that over a long period of time, and eventually came to the conclusion that it was fine to use efavirenz in pregnancy. And considering that there are going to be many women on HIV treatment who get pregnant on efavirenz, then I think that's pretty reasonable that they're allowed to continue efavirenz. So I wouldn't have any. If this woman is in a low or middle income country, I would have no problem in starting this woman on efavirenz with all the caveats that our Thai colleague has said. In first world countries, I think there's not enough data on integrase inhibitors during pregnancy. Efavirenz is generally not recommended in first line in high income countries, so I'd probably go with a boosted protease inhibitor, which is the usual recommendation in high income countries. But having said that, I think efavirenz is a perfectly reasonable choice, and I think we're just a bit prejudiced against it, and the data is not there to say that there are increased birth defects.
Yeah, just a little to add. I would strongly agree with what David said, because most women who are becoming pregnant are on efavirenz worldwide, and so the biggest data set is from women who are on efavirenz. So in all fairness, we have much more safety data with that compound than with any other compound altogether. In the European setting, there's a strong discouragement to use any integrase inhibitor other than raltegravir because of the lack of data. There has been one report at CROI last year with some signal around dolutegravir in pregnancy, so there's still some unknowns there. Raltegravir is being recommended predominantly for women who present late, so that doesn't really apply to this patient because she comes at week 12 of pregnancy. But if you are very late and you want to have viral load down fast enough, and obviously integrase inhibitors have a much faster decline, and then you can reduce the risk of transmission. So that would be the reason. So we would go with the boosted PI here.
Yeah, thank you. We have many new drugs for HIV treatment naive patient in the guideline, but please be very careful because some of new drugs don't have safety data for pregnant women. Don't jump on that. For example, boosted elticavir, we now do not have any dose recommendation for pregnancy because insufficiency of data to make dose recommendation. This is the same thing happened with dolutegravir. Only one integrase inhibitor that may be safe in pregnant women is raltegravir, and as Juergen mentioned, benefit of raltegravir is the greater reduction of the plasma viral load comparing to the other agents. So it might be a good choice in pregnant women who presented at really late stage of pregnancy. So would you want to get the virus came down very quickly before delivery? This is maybe the role of raltegravir in pregnant women. This is the recommendation in the HHS guideline. This is a recommend ART regimen in pregnant women. They recommend prefer to an RTI backbone. The recommendation are abacavir plus TTC, CDF, FTC or 3TC, ACT plus 3TC, no TAF at this time. And preferred third agent is boosted PI, whether it could be boosted atazanavir or boosted darunavir. And efavirenz may be used after the first 8 weeks of pregnancy. And in this guideline also mentioned the role of raltegravir in pregnant women, that this is safe and should be given twice daily. So in this case, patient wish to have the drugs that have minimal side effect on CNS. So I talked to her and I choose TDF, FTC plus boosted atazanavir for her. I'll move on to the third case. The third case is a young MSM with recent HIV infections. He is 25 years old man, presented to HIV clinic for PrEP. Actually he won PrEP, but HIV testing was done before PrEP initiation, and turned out that HIV is positive. He had history of taking PrEP for 10 months ago with the other clinic, and he admitted that he had poor adherence to TDF-FTC for PrEP. And at that clinic, HIV test was performed and was negative. So we sent his CD4 and viral load testing, and result came back CD4 at 458, and his viral load is very high, 2 million copies per ml, and his syphilis serology and hepatitis B C serology are all negative. So in terms of the treatment regimen, what is your preferred regimen in this young MSM with recent HIV infections? A. Abacavir 3TC plus dolutegravir. B. TDF-FTC boosted elvitegravir. C. TDF-FTC boosted darunavir. D. TDF-FTC dolutegravir, or E. something else. Please vote. It's spread out. I want to ask who answered number 5. Anyone? Could you raise your hand and tell us what you thought? Okay, maybe.
What did he say?
You want to come to microphone and no? Oh, okay. It's concealed now. All right. What would you do, David?
So, can we go back to the story? So firstly, he's at risk. He's been taking PrEP, but his adherence hasn't been good. He got infected while he may or may not have been taking PrEP properly, and therefore one has to question whether he has resistance, or indeed he could have a transmitted resistant virus. He's clearly recently seroconverting. You probably know that because he had a negative test 2 months ago, but it's certainly confirmed by the very high viral load. So you do need to start. I think you do need to start him on treatment. He's at risk of infecting, other partners, particularly if his behaviour is not that he hasn't been taking his medication properly and maybe using recreational drug use and so on. So I think you do need to start him on treatment. I don't think you should probably start him on abacavir without a 5701, so that unfortunately wouldn't be a good choice. But I think any of the others are reasonable choices. My preference is not to start a boosted PI first up. I just don't think that's necessary. So I'd prefer an integrase-based regimen, and I'd use either the alvategravir or the dolutegravir with tenofovir FTC. I would make sure that the baseline the baseline sample goes straight away for a genotype. and if it's not wild type, then you may have to adjust his regimen.
Juergen.
Yeah, so I think the probability of having an M184V is extremely high. So with that in place, I would not use an abacavir-containing regimen because the abacavir and 3TC are a weak backbone in the presence of 184V. Having TDF on board in the presence of a 184V is much better because it becomes hypersusceptible, and then most likely in combination with a third agent will take care of a relatively high viral load. Personally, I would not use elvitegravir in this context because that has the weakest genetic barrier. Already having the 184V, if that compromises, would not and would be too risky, I think. And you don't. Obviously, there's also the risk that you got some other resistance transmitted too. So the genotype, I think, here is very pivotal, and I do understand that people want to have the genotype as fast as possible to make the best choice. I think that in some of the European countries, from the consensus definition we have in the lack of a resistance test, there still is a preference to use a boosted PI in many countries. So that's a little contrast to what David said, which just resembles that you that have that high genetic barrier, and all data in the presence of a 184V suggests that you have very good response rates with a PI. So for me, it would be a dolutegravir or boosted PI plus TDF FTC combination.
Back to his story. I think after I read his history, I have some point that kicked my mind. The first point is that he received the PrEP from the private clinic 10 months ago. So that maybe I have to ask him about how it's possible to receive it from the private clinic. I didn't know, but now today maybe it's possible. The second one is he is just a recent converter. So the point is the viral load is very high. Is he look handsome? Is he look smart? What is his career? So this is the period that he will spread the infection to the other. So I will counsel him vigorously about how heavily his virus can spread to the other if he still have the active sexual life until his viral load is undetectable. So the choice of the first line regimen, I don't think that is most important for this patient right now. Before we emphasize him that how is the spreading of the infection too, especially if we get the genotype that is resist. But I don't know the result of genotype, but I will counsel him that at this period, please have the safe sex and not spreading.
Thank you. So in this case, we talk to him and consult him on the risk of transmitted drug-resistant virus because he has multiple sexual partners that may carry drug-resistant virus, and he also not adherent to PrEP. So I think risk of primary drug resistance is very high. I send genotype and then I choose the regimen for him. Abacavir is not a good choice because we need to have HIV star 5701 come back before start, so it may be delay our treatment because in this setting we want to start the treatment right away because we have the opportunity to lower the viral set point and prevent dissemination of the virus to the other organs, for example, to the brain. So I think it's kind of urgent to start the treatment. So we start with TDF, FTC, boosted elvitegravir, and then we send genotype first, and then we start with this regimen, and then wait until the result come back, and then adjust the regimen again according to genotypic resistant testing. So the key of the management in acute or recent HIV infection is you must initiate antiretroviral therapy at very early because like yesterday, many people talk about the treatment the benefit of treatment in patients with acute or recent HIV infections. there are potential benefit of treatment in this setting. For example, the treatment will reduce the symptom and lower viral set point and the size of reservoirs. That may be implication for cure in the future. And genotypic resistant testing should be performed before initiation of the treatment and used to guide the therapy. The recommended regimen, this is from the guideline, DHS guideline and IS guideline recommend TDF-FTC plus boosted ritonavir, and also recommend TDF-FTC plus dolutegravir. And in European guideline, recommend TDF-FTC plus any integrase inhibitors. There are some people who get infected during PrEP. This is the report of this is the data that's shown that some people get HIV infection during PrEP. One of the reasons that they get infected because they take PrEP during occult HIV infections, and the common mutation that found on that situation was M84V or I. And there are one case report that the patient had transmitted HIV infection that have MDR HIV from during PrEP in Croy last year. So this is the outcome of this patient. We sent genotypic resistant testing and come back to be wild type, and I start him with TDF-FTC boosted elvitikavir and then switch to TDF-FTC efavirenz. So we move on to...
Can I just make one comment? I don't think you should wait in a public health sense for the genotype, right? Because I just think he should be put on treatment. You don't know whether he's very infectious, and you don't know if he's still going to have, multiple sexual contacts. And I think and that's another reason for me to use an integrase inhibitor to get his viral load down. So I'd start him straight away and wait for the resistance test to come back.
Yes. This case, we start the treatment right away, and then we also send genotypic resistant at the same time when we start. And then when it came back, we switch the regimen to cheaper regimen and more affordable regimen, because I have to put him on Thai health scheme. So the next case, the case number 4. Case number 4 is a 60 years old woman present to the clinic with diagnosis of HIV infections. And her physician started TDF-FTC efavirenz 8 months ago, and her baseline CD4 was 4000, and her baseline virus was 3,000 copies per ml, and last viral load was 1 month ago was less than 20 copies per ml. Her hepatitis serology all are negative. And she also has underlying disease. She has diabetes type 2, which on metformin, on metformin, and has hyperlipidemia on atorvastatin, and she also has hypertension now on amlodipine 10 milligram per day. At the follow-up lab, her creatinine level increased from 0.9 to 1.9 recently, and we checked that she has evidence of proximal tubulopathy. For example, has proteinuria, glycosuria increased during excretion of phosphate. I think this is from tenofovir. So the diagnosis is tenofovir-induced nephrotoxicity in patients with underlying disease, diabetic, hyperlipidemia, and hypertension. So we talked to the patient to switch the therapy from TDF-FTC efavirenz to the other regimen. So what is your choice for switching in this case? A. Abacavir 3TC dolutegravir. B. Abacavir 3TC plus efavirenz. C. Boosted darunavir plus TTC. D. Boosted darunavir plus raltegravir or something else? Please vote. So what is your idea, Juergen?
Yeah, so I guess it depends on the availability and the guidelines you have, and obviously if there is a clear cause of TDF-related toxicity, that it would make sense if you don't have TAF and if you don't, to switch to abacavir. So I think most people chose abacavir 3-TC efavirenz for that very reason. My concern would be that obviously the patient has dyslipidemia, diabetes, and hypertension. So there are 3 independent risk factors for cardiovascular disease. So that would be the high-risk cardiovascular person where you would then start abacavir, which is sort of a risky thing. The only beneficial thing that she's female, that's at least a little bit protective potentially. So that would be at least something to worry about. Dolutegravir is, with abacavir, obviously you have the same problem, so I don't think that really adds that much because it's not an efavirenz problem. The dolutegravir also has an issue with metformin interaction. You have higher metformin exposure and an increased risk for lactic acidosis. 3-TC and boosted darunavir, I think, is an option to get rid of the tenofovir toxicity, but then you have a boosted PI which may interact with some of the co-medications, and obviously that may also have an impact on lipids, at least a little bit. Something else, at least in our region, some of the people would feel that maybe raltegravir plus an NN-RTI would be an option, because that seems to be an increasingly sort of interesting regimen because it does not have the nuke toxicity, so you wouldn't have the tenofovir in there, and you also wouldn't have the boosted PI in there, and so for cardiovascular issues, raltegravir plus an NN-RTI would be, I think, also a feasible option, but obviously that does increase cost and may not be something implementable in the setting of limited resources.
So you mentioned a very good point, because if we use dolutegravir in this case, it will increase level of metformin. So you need to be very careful on this, because there's major interaction between dolutegravir and metformin. And what is your thought, Ajahn Churiat?
Okay, back to the history again. Okay, this is the maybe elderly woman, 65, the same age with me. Okay, the point, the first slide, okay.
We have to redefine elderly then.
What's a bit disappointed that usually in the elderly there is a study that the adherence is better than the general, but in this case she failed in the first 8 months, like something like that. How long that she had
she had on the treatment for 8 months.
8 months. That means that he have the early fail, the viral load. You can suppress or?
Yeah, finally suppressed.
And
okay.
The last. You can suppress.
This is the last viral load.
Okay. So she is suppressed. But the problem is her renal function is starting to have the impairment. What is her body weight? Because when you have the elderly one, when you have the body weight is one of the factor, and also the baseline of the creatinine, the initial creatinine. If her renal function is compromised, when you use the tenofovir, if you use a full dose, maybe she might develop the renal impairment like this. So if I have a choice, I will review the dosing of the tenofovir. But if the tenofovir dose is already proper, it means that we have to check what is the concomitant medicine that can create her renal impairment. If there is no, maybe tenofovir may be the best or proper choice for her. Maybe have to change. And of course, in Thailand, we have not many choice. Maybe start with the abacavir. Before starting the abacavir, one question that we ask her is a family history of the coronary heart.
Thank you. And David.
Yeah, so I call this patient a rate patient, R-A-T-E, and it means avoid ritonavir, abacavir, tenofovir, and efavirenz. And there are all the reasons for that you can see. She's got diabetes and hypertension, she's got cardiovascular risk, she's got renal risk, and she's got drug interaction risk, right? So in those patients, I think that's what Juergen was getting at. I try to come up with a regimen that would suppress, she's going to be adherent, right? Come up with a regimen that would suppress and doesn't have the problems of those drugs. So I think there's a number of options there. I think something with etravirine, with raltegravir, with maraviroc, if your CCR5 are really quite good options. There's also rilpivirine, dolutegravir is quite a good option. I have to disagree with my esteemed German colleague about the interaction of metformin and dolutegravir. I think it's overrated. Metformin is in fact a pretty safe drug, and I think the risk of lactic acidosis is really quite low. If you were concerned about the drug-drug interaction, I'd perhaps reduce a metformin to 500, but I don't really think that I'd be too concerned about that interaction. So I would probably use something like rilpivirine, dolutegravir, or maraviroc, raltegravir. I understand in Thailand you've got problematic availability of these sort of combinations. So for me, I think C is probably a very good choice, and you just need to be careful with the drug-drug interactions with ritonavir and atorvastatin and her calcium channel blocker.
Thank you. So what did we do on this case? We sent HLA-B star 5701 and come back negative, and then I switch the CDF to abacavir. And we also concerned about cardiovascular risk in this case. We look at the risk, and I look at her hemoglobin A1C level, and it was okay. And she doesn't have any micro or macrovascular complication from diabetes, and her hypertension is okay. So I think we strong enough to give her abacavir. I think it is safe for this time. But in the future, if this condition become more complicated, I may switch again to the other regimen.
May I add one point? I think this is a common side effect of the tenofovir that we have to face with the, even we reduce or adjust the dose, the patients still have the renal impairment. Back to last year, abacavir is not available in Thailand. So we have to, if we have to away from the tenofovir in the subclass viral load patient, no history of the resistance. Another way to go is maybe simplify with the two drugs. We should have the two study about the TTC and protease inhibitor. That means the OLE study of pitocan, and also the South study of the TTC and atasanavir. this just only used in the very limited case that you have no choice, and this maybe you have to follow. There is a data until 2 years already, and in my institute we have the data up to TC and lopinavir in the 100 case follow more than 4 or 5 years. Maybe another choice to away from tenofovir in the subclass viral.
Yeah, let me just add one thing with regard to the metformin story, because I agree. I wouldn't overrate it in the sense that it is that you can't use it, but remember that the patient does have renal insufficiency, so there are other risk factors for getting lactic acidosis. And I think what we forget is that we are now taking care of patients who are 65, may look much younger, but in a biological sense, harbor a risk, and diabetes and hypertension cause renal damage, which will increase over time. So there is an inherent risk for metformin toxicity, and I think that's not necessarily going to help to have a regimen. I think in the setting of a resource limited, I think the idea of a 3TC and boosted PI, despite the risk of drug interactions, but you can choose that with the drug interaction website, is attractive, because remember, the patient, if I understand it correctly, had a viral load which was very low in the beginning of only 3,200 copies. She's just going to respond to everything, so she's probably only going to need, if at all, a boosted PI even as a monotherapy, and atazanavir has the least risk for changing insulin sensitivity or lipids, so that's something to keep in mind.
Thank you. So I will go with the last case number 5. This is a 32-year-old man present to HIV clinic for a routine visit. He started treatment in 2006 with ACT3TC efferents, and then switched to TDF-FTC efferents because of lipodystrophy, and he want to have an OD regimen, so this is part of treatment simplifications. And at this visit, he previously undetectable. For this time, his virus increased from undetectable level to 30,000 copies per ml, and her CD4 cell count, his CD4 cell count is 670 cells per ml, and he admit that he missed many doses of ART during past years. He is active drug user and admit history of condomless sex with anonymous partner, and we sent genotypic resistant testing, and it's come back with M84V and K103N. This is the genotypic resistant testing, and this is the pattern of susceptibility of his virus. So the question is, how would you choose the regimen for this case? What is your preferred regimen? A, TDF-FTC boosted PI. B, TDF-FTC ethylene. C, boosted lopinavir plus TTC. D, boosted darunavir plus raltegravir. E, something else. This is resistant pattern. Please vote. Most of you choose A, TDF-FTC plus boosted PI. What would you do, David?
Okay, so this is a classic first-line failure with M184V and K103N. So what do the guidelines say? The guidelines say to change around the nukes and use a boosted PI. and I think that is the the thing that you would do. You do have the advantage of resistance testing here in Thailand, so you've got the added advantage that that you know this person is tenofovir susceptible, so therefore using tenofovir FTC with a boosted PI is a very good choice. The randomised clinical trials of second line and Earnest show that an alternative regimen in this situation is a boosted PI and raltegravir, so option D is also a good choice. I don't think I'd use etravirine in this patient, although it would cover K103N, but I just don't think that regimen would be strong enough in a patient who's a bit chaotic. I think you need a boosted PI. The 3TC and boosted lopinavir, I might be convinced because there is good data that a boosted PI and the use of 3TC even in the presence of M184V where you get about half a log in addition is okay, but lopinavir is not the best of the PIs compared to darunavir, so I'd be less comfortable with that. So the guideline-based regimen I'd select would be A, and the alternative would be D.
Okay. Juergen.
Yeah, it's good to see that Professor Cooper sees use of PIs, at least in some patients. I think one addition could be dolutegravir plus TDF and FTC, because there's also some data suggesting that in the presence of a 184V, that would also have enough potency, so that could also be another regimen. I think for me the 3TC plus the boosted PI data from Cameroon, which was presented at the Glasgow meeting, was very interesting to see that despite over 90% of the patients in that trial having the 184V still had good responses, but clearly with the high hypersusceptibility in the presence of the 184V, TDF I think would be a perfect second NRTI choice.
I think this is the classical first-line failure with the NNRTI-based regimen. In Thailand, we have conducted a study to answer this question. The name of the study is HIPSTAR. I think during the 2010 or 11 to compare randomized control trial study to compare. At that time, I feel a bit sorry that we use only lopinavir, following Alibas idea, and compare with the two NRTI and lopinavir without knowing the result of the genotype. And it's proved that when we recycle two NRTI and lopinavir, it's work. So the choice for real life in Thailand may be number A or number E. You can, if you want to use other two NRTI, it's possible.
Okay, great. Because I try to put this case in the slide because some people may think that Italian is safe in this setting, but don't use this because it might not be safe to use Italian in combination with the other drugs because these drugs has lower genetic barrier comparing to the other regimen. So I think it should be keep for the third line. So what did we do in this case? We designed the new regimen and we switched the regimen to TDF, FTC, and plus boosted lopinavir. And the other thing that I would like to emphasize is when this is the data from second line failures. This is a second line trial that David involved in this trial, and they look at the factor in the patient who failed first line. What is the factor that they failed second line? The most important thing is the adherence. They found that the patient who were non-adherent to the first line still also non-adherent to the second line. This is the key message from this this slide. You should look back and look for the reason why your patient failed. If the patient not adherent to the first line, you need to do more on adherent counseling to make your patient adherent to the second line and the third line. So I think we are running out of time, and we have 5 minutes for taking questions. If you have questions, please go to the microphones and ask us. Any questions from the audience? Okay. Please come to the microphone and identify yourself and ask the question.
I have a question. That I have met a patient, and he has been taking TTF, 3TC, and Ivava for 2 years, and suddenly he developed psychological symptoms such as insomnia. So should we switch regime from Ivava to other regimen if he or she develops psychological symptoms?
Yeah. So I think one of the interesting thing about efavirenz is that there is an ongoing remaining long-term toxicity, and if you look at some of the trials, you see that every year there's a discontinued rate of people who stop because of CNS toxicity. And since having toxicity of a regimen will impact adherence over time, yes, I think it makes perfect sense to switch the patient to a different regimen, which would be one option. You could also say, well, if he has CNS toxicity, he may have a high drug level, and you may consider a lower dose. I don't know if that is like, if there's a cost issue, whether that would also be a feasible option. But I think switching the patient with insomnia, which impacts daily life and functioning, is a good reason to switch to a different regimen. And since he's been suppressed all the time, presuming he was wild type before, all options would apply.
So the only caveat to Professor Rockstroh's excellent response is that yes, it is true that people do get insomnia to efavirenz at any time, but it usually happens fairly early on, and you know early on whether they're going to be intolerant to efavirenz. So I think for me that's a signal of whether anything else is happening, right? So is there a mood disorder? Is the patient using recreational drugs? Is there something else happening? It wouldn't mean that I wouldn't change the regimen, but it would be a high alert to to look for some other clue, to look for something else happening in the patient's life.
I think the sleep disturbance from efavirenz is one of the common side effects, undesired side effects that we often heard from the patient. There are 2 points. The first point is that we can reduce the dose to 400 milligram confidently according to NCOR1 study. If you did not reduce, you can try. Because some of my patients, they answer me that it's better. The second point is most of them told me that if they take the efavirenz during the fasting stage, the side effect may be more. So maybe you can use these 2 points to alleviate the undesired symptom before switching or changing the regimen.
I also have another question. It's a female. She has been taking ART, TTF, 3TC, efavirenz for 1 year, but she got pregnant. She got pregnant, and then we did the viral testing at 34 weeks of pregnancy, and the viral load is a little bit high, about more than 2,000 copies per ml. And I want to ask, should we change to second-line boosted PI, or should we wait for her drug TRS, or just remain the TTF, TTC, efavirenz regime?
So this is another patient?
Another patient.
Yeah, okay. I don't think it's tolerable to have a viral load of 2,000 copies in a pregnant woman. Even though the risk of transmission is very low with that viral load, I still think it's not safe to do that. So I would do a resistance test and change her regimen. If it was still wild type, then there's an adherence problem, and maybe she's getting more higher efavirenz levels during pregnancy, and you probably might want to switch it anyway. I would definitely change her regimen, yeah.
For this case, I think I'm gonna switch the regimen right away because you have limited time.
Yes.
Because you need to have virus down below to the undetectable before the delivery. So I'm gonna switch the regimen right away to boosted PI regimen and then send genotypic resistant testing and then look again whether I could adjust the regimen according to genotypic testing result.
Unfortunately, we don't have any resistance testing yet. That's why.
Yeah, that's why the immediate switching is, I think, the most feasible option, because if you use a boosted PI and 2 nukes, you know that pretty much to the patient you had before with the 184V and the K103N, that would be the likely mutation scenario. And if you would use the boosted PI with 2 nukes, you would have taken care if the mutations were there. If they're not there, then adherence counseling and giving that drug should work as well. I think the fact that she has 1,200 copies, if that's the viral load I understood, that at least makes it very likely that there are mutations, because otherwise you would think she might be somewhat higher, and so it's suggestive that they're under drug pressure something happened.
Thank you.
Okay. Yes.
Thank you very much for the presentation today. It's very interesting, and I am a doctor from Myanmar. In our country, we are using Abacavir as not the first line, but if the patient is intolerant to tenofovir or zirobutane or the other drugs, then we use Abacavir. In that case, we cannot test HLA-B 5701, so we just give the patient with the Abacavir. And I just want to know, is there any study in Thailand, because we are a neighboring country, about the prevalence of HLA-B 5701, because we didn't have in our country. Maybe we can think about it. Is there anything study about?
Okay. Yeah, the issue of we need to test the 5701 before starting the Abacavir. I think that Abacavir is not a new drug. It's since 1999. I am also one of the investigators of the Glaxo that we have a chance to check the 5701 in Thai people. Is it lesser than 1 or 2%, but also similar with the Japanese. So for my idea, I don't think that it's mandatory or necessary to have the result of 5701 before starting the Abacavir. But unfortunately, our guideline follow the Western guideline. Even in the National AIDS program, if you didn't have the result of the 5701, you cannot be permitted to use it. And another point that I'm have a confidence to use without the 5701, because I learned that the hypersensitivity of the Abacavir is very classical, and the onset should be at the end of the first to the second week, and there is the symptom that very classical, so we can diagnose or we can know or aware of the case. The point is that don't re-challenge it at that point. So in Thailand, if there is a debate, this one may be one of the debate that should we have to mandate the 5701 before starting Abacavir.
So just make one comment that as you go from west to east, 5701 prevalence goes down, so it's around 8% in Caucasians and, almost never in Japanese. But there is a certain low percentage in Thailand. I think you said you're from Myanmar, is that right? Yeah. So, you're bordering India. The prevalence of 5701 in India is getting up there towards the Caucasian, the Caucasian prevalence. So I'd be very cautious. But you can manage a Abacavir. We didn't have B5701 when Abacavir became available, and we learned to manage how, the hypersensitivity reaction and to counsel the patient, and the reaction is very classical. So.
I have the figure in Thai patient. They have allowed 6% of the patient will develop hypersensitivity, maybe similar to the Myanmar. So of 6% of the patient when you start, maybe you have to follow. And now today is the life is easier. We have the mobile, we have everything. So how to follow up?
Thank you. I have a second case, if it is allowed. And we have a child on ARD. We at less than 2 years old, so we started with PI-based regime. And the child needs TV treatment with rifampicin. And then we have only two options. One is a booster PI, and the second one a triple nuke regime, because efavirenz is not allowed to use in that age. So yeah, from yesterday's discussion, there was a study in South Africa. They mentioned about the even though you increase the ritonavir dose 1:1 level in the children, but it's not the same with adult, but it's the drug level will be reduced. So in our setting, a triple nuke is also something weak. Traditionally, I believe is a really weak regime, but I don't know. So in that kind of setting, what treatment regime will be suitable for the baby, for the children?
Yeah, so you're talking to 3 adult physicians here. I don't think I'd take any of our advice with a grain of salt. You really need to consult a specialist in, us. There's plenty of people around here who are very experienced in pediatric HIV. But there is a serious drug interaction between rifampicin and boosted PIs. That's absolutely true. You can use rifabutin, but this is adults, right? You can use rifabutin, but it's not widely available, of course.
Okay. One last question from Dr.
Thank you.
Anjali. We need to move on fast because.
So just very. So since the HIV hepatitis B co-infection is quite common in this region, and now we have seen more cases with the chronic kidney disease, and we cannot access to TAP or entecavir, and hepatitis B S antigen still positive, and high hepatitis B S antigen quantitative. So what would you recommend us to do? For example, if the patient have clearance less than 30?
Yeah. That's a great question, right? So if I understand correctly, GFR is less than 30, you have chronic hepatitis B, tenofovir obviously is an issue with below 30, and there's 3TC resistance, so entecavir is also not an option. And I think, quite frankly, I don't know what we would really recommend because there's no good choice you can do. You wonder whether you could even, stagger your tenofovir even longer. I have to say that all the cases I've seen with entecavir have all failed. So it's not going to work. So I think in the lack of any other option, I would try to down titrate my tenofovir.
You couldn't get compassionate TAF for that patient? Because there is a compassionate Descovy.
Yeah, that's the only compassionate use program they put up. It's for that indication. That's right.
It will take at least about 3 years to get TAP into the country.
Yeah.
So maybe just let them go that way with the lower dose tenofovir.
Yeah.
All right, thank you. So I would like to end I would like to say thank you for your contribution with us, and hope to see you again next year in HIV medicine in Bangkok. Thank you very much.
Thank you.